I might ask all of our panellists to turn their videos on. And good morning, everyone. I'd like to start by first of all acknowledging the traditional owners of the land on which we are meeting and pay my respects to the elders past, present and emerging, and welcome any Aboriginal people here today at this virtual press conference. My name is Professor Sharon Lewin. I'm Director of the Doherty Institute. Doherty Institute is a joint venture of the University of Melbourne and Royal Melbourne Hospital and located in Melbourne, Australia. I'm an infectious diseases physician and basic scientist virologist, and I lead a national network called the APRISE network, which focuses on pandemic preparedness and has been supporting two major clinical trials that we're going to talk about today, ASCOT and REMAP-CAP. Now, as many of you know, treatments along with better diagnostics and vaccines are one of the key components of our response to COVID-19. If we can get better treatments, stop people going to hospital, stop people going to intensive care, and stop people dying, we could have a huge impact on this pandemic. And there's been extensive work on trying to develop better treatments for COVID-19. And it's a very complex space because treatments for COVID-19 need treatments that target the virus and also treatments that target the immune system and treatments that target complications of COVID-19. But over the last 6 months, we have definitely seen some progress in that area. We now have one treatment which certainly reduces mortality. That's dexamethasone, a steroid that's given to people if they're on oxygen or in intensive care and can reduce mortality by 20 to 30% and now being used across Australia. And we also have one antiviral drug that's been approved here for use in Australia by the TGA, and that's remdesivir, a direct-acting antiviral drug, but whose efficacy is not as good as dexamethasone, and to date has only been shown to reduce time to recovery, an important outcome, but hasn't been shown to reduce mortality. But today we're pleased to tell you about a new potential treatment option that will be available to Australians as part of a clinical trial. And the treatment option is convalescent plasma. It will be available through two major clinical trials that are happening now across Australia: the AustralaSian COVID Trial, or ASCOT, and the randomised embedded multi-factorial adaptive platform trial for community-acquired pneumonia, REMAP-CAP. I've known about REMAP-CAP for about 3 years because it started before COVID-19, but I can never remember the acronym, so I need to read that one. So these two clinical trials are complementary, but they target different populations. ASCOT aims to test treatments for people with COVID-19 who are hospitalised and to see whether the treatments can prevent patients to requiring a ventilator or going to intensive care. So it captures people with moderate to severe disease, but who are hospitalised but not yet in intensive care. REMAP-CAP is complementary to ASCOT because it's investigating multiple treatments for community-acquired pneumonia already in intensive care. And REMAP-CAP started well before COVID was around. It's an international study with over 200 sites and active in 14 countries. So I'd like to introduce our panellists today. First of all, my colleague, Associate Professor Stephen Tong. Stephen's an infectious diseases physician at the Royal Melbourne Hospital and is co-lead of clinical research at the Doherty Institute and is the principal investigator of ASCOT. Associate Professor Zoe McQuilton. Zoe is the Australian lead investigator for the convalescent plasma domain of REMAP-CAP and also the co-chair of the convalescent plasma domain for ASCOT. She's a haematologist at Monash Health and Deputy Director of the Transfusion Research Unit at Monash University. And finally, Dr. James Daly, who's the Medical Director for Pathology Services for Lifeblood, who generate the convalescent plasma. So I'll hand over, just briefly how we'll run the media conference. I will hand over to each of our speakers who will speak for a short period. We'll then open up for questions, and we're aiming to close the conference at 10:45. Rebecca Elliott, who's our communications manager at the Doherty Institute, will manage the questions, and we'll have questions from about 10:15 to 10:45. So first of all, hand over to Steve. Welcome to Steve Tong.
Thanks very much, Sharon, and thanks for the opportunity to speak to everyone here. Look, as we observed the pandemic in China initially back in January and February, and started seeing a few patients during the first wave in Australia, we identified the importance of setting up a clinical trial to offer treatments to patients with COVID-19. Such a framework allows experimental therapies to be offered with ethical and governance oversight, and allows us to learn about whether these treatments are effective. But it's very challenging to run a trial properly during a pandemic. Setting up a trial typically takes months, maybe years, and obviously we didn't have months. And key challenges so far have been that once we got ourselves ready, the first wave in March and April was passing in Australia. The treatments we initially included made a lot of sense back in March. These were agents with some activity in the laboratory, and early clinical reports showed promise. But of course, everyone else had the same idea, and hydroxychloroquine and lopinavir-ritonavir, the two agents that we chose, were both being widely used and also included in many trials overseas. These trials have recruited quickly overseas, where there's been much larger numbers than in Australia and New Zealand, and they rapidly generated data. And even if only in press release or preprint form, these data have suggested that hydroxychloroquine and lopinavir-ritonavir aren't effective in improving outcomes for patients with COVID-19. So by the time our second wave arrived in June, clinicians in Australia and New Zealand no longer felt that we should be testing hydroxychloroquine and lopinavir-ritonavir. And also relevant was these other developments that Sharon's mentioned, and especially this other antiviral drug, remdesivir, which has been shown to have activity and clinical benefit and was now available for use in Australia. And given these options, remdesivir was being preferred over hydroxychloroquine and lopinavir-ritonavir. So our trial steering committee decided we needed to pivot, and we've now suspended the use of hydroxychloroquine and lopinavir-ritonavir, and we've introduced convalescent plasma as a therapy. And this has involved working really closely with our haematology colleagues and with Lifeblood Australia. So we obtained ethics and governance approval for the use of convalescent plasma last week at the Royal Melbourne Hospital. And on Tuesday, we recruited our first participant. And this patient is the first person in Australia to receive convalescent plasma as a treatment for COVID-19. And I'll hand over to you, Sharon, for Zoe to explain a bit more about convalescent plasma.
Great, thanks, Steve. And thanks for the update on other changes to ASCOT that I suspect will also generate some questions. And I'm going to invite Zoe to tell us a bit about convalescent plasma, how it's used. Welcome, Zoe.
Thanks, Sharon, and thanks for the introduction. So just a bit of a background about convalescent plasma for the audience. So people who recover from COVID-19 develop antibodies against the SARS-CoV-2 virus, and these antibodies are present in the blood. So convalescent plasma is a blood component that's collected from individuals who have recovered from COVID-19, and therefore it will contain the antibodies directed against the virus. We're interested in testing whether the transfusion of convalescent plasma to patients who are unwell with COVID-19 will help control the virus and therefore improve their clinical recovery. Convalescent plasma has been used in previous pandemics, including to treat other respiratory viruses such as influenza, SARS, and MERS, and there is some evidence to suggest that it may be beneficial. We also know that convalescent plasma is now being used to treat patients with COVID-19 internationally. Initially, there were some small case series that were reported early in the pandemic from China, but more recently we've seen large case series of reports of the use of convalescent plasma in thousands of patients. And these reports suggest that the use of convalescent plasma is a safe treatment. However, there have been few clinical trials that have compared the outcomes of patients who have received convalescent plasma to patients who have received standard care. And those few clinical trials have been too small to answer the question of whether convalescent plasma is an effective treatment. So in Australia, we're planning to study the use of convalescent plasma for the treatment of COVID-19 in these two complementary trials, as Sharon's already outlined this morning. The first is ASCOT, which will evaluate whether the use of convalescent plasma as a treatment for patients who are hospitalised but not yet requiring intensive care support will benefit from the use of convalescent plasma. And then the Australian-led global REMAP-CAP study will evaluate its use in treatment for patients who are critically ill with COVID-19. So these two trials are going to test if convalescent plasma therapy is effective at different stages in the course of the disease. Now, these trials are possible through our collaboration with Lifeblood, who started collecting convalescent plasma from Australian donors in May. And we have enough convalescent plasma to open these trials. And as we've heard, we've treated the first patient at the Royal Melbourne Hospital this week. However, we will need more donors to allow these trials to continue. So I might leave there and hand back to Sharon, who will introduce James.
Great, thank you, Zoe. Very clearly explained, and we of course couldn't do this without the support of the Australian Red Cross Lifeblood. So over to James, who'll tell us a little bit more about how the plasma is collected.
Thanks very much, Sharon. So yes, the Australian Red Cross Lifeblood is proud to be working with these two clinical trials to study the role of convalescent plasma for patients suffering from COVID-19. And we need to thank our amazing donors whose generosity enables these important trials to be undertaken. But today we're calling for more convalescent plasma donors from people who have recovered from COVID-19. As Zoe mentioned, we started collecting convalescent plasma in May. And since then, we've collected more than 1,000 convalescent plasma donations from 474 donors. Convalescent plasma donors can donate as frequently as weekly. And we have collected more than one donation from over 270 donors. But with the growing numbers of cases in Melbourne and Sydney and the rising numbers of hospitalised patients, it's difficult to predict the volume of convalescent plasma required to support the two clinical trials. So we are urging anyone who's potentially eligible to come in and donate. In particular, we're looking for male donors who've fully recovered from COVID-19 to donate their plasma, because plasma from male donors is suitable for use as direct transfusion as clinical convalescent plasma. But we don't want anyone to discount themselves as a donor. Certainly females who've recovered from COVID-19 can donate convalescent plasma, and their plasma will be used to make a concentrated antibody product called COVID-19 immunoglobulin, which will also be used in trials for treating patients with COVID-19 infection. So donating plasma is a simple and powerful act that could help a patient struggling to fight the disease. And it's a real opportunity for people who've battled COVID-19 and recovered to become part of the solution and to help other patients. Safety is Lifeblood's #1 priority, and there's no increased risk to donors or our staff or from patients from this initiative. Our convalescent plasma donors have to satisfy the same strict eligibility criteria as our other donors. And the process of collecting and manufacturing the convalescent plasma is exactly the same as general clinical plasma. So to donate, our donors have to have a laboratory confirmed case of COVID-19. They have to have been free from, and any symptoms have to have resolved for at least 28 days. And they need to meet all the existing eligibility criteria for blood donation. We're encouraging donors to come early on after that 28 days of recovery from symptoms, because the antibody titers may be higher in that early period, and to donate more than once. So if donors think that's appropriate for them, that they can call 13 14 95 and just mention convalescent plasma, and we'll talk through eligibility and book them appointment. And certainly if you know someone who may be eligible after recovering from COVID-19, to contact Lifeblood and make an appointment. So given the current outbreak in Melbourne, we're expecting that 28-day period will be coming up in the next week or two for a good number of people, and we are calling for people to come and make an appointment.
Great, thank you, James. I'll now hand over to Rebecca Elliott. As I mentioned earlier, Rebecca is the Communications Manager for the Doherty Institute, and she'll facilitate the questions from our audience. So over to you, Rebecca.
Thanks, Sharon. Now, everyone will have an option at the bottom of their screen to raise your virtual hand. So if you do have a question, raise your virtual hand and I will facilitate that. First question is from Sophie Scott. Sophie, please go ahead and ask your question.
Oh, hi. I was just wanting to find out what the efficacy has been for the convalescent plasma overseas, and what could be the potential efficacy of it here when it's included in these two trials.
I might ask Zoe to respond to that.
So there's been one clinical trial of approximately 100 patients that was reported from China, which was terminated early because the number of cases declined. They couldn't complete their trial and reach their target sample size. They didn't find a difference in their primary outcome or the clinical recovery. They did, in patients who were more severely unwell, there was a signal that it may have been beneficial. And in one of their secondary outcomes, looking at viral clearance, there was evidence that the virus was cleared faster in patients treated with convalescent plasma. But the study was overall too small to really answer the question about whether convalescent plasma is efficacious for the treatment of COVID-19. The other studies that we have are a small case series and a large sort of safety study from the US, which has reported on more than 5,000 patients with COVID-19 who've received convalescent plasma, but that hasn't looked at efficacy. That's just reported the safety profile of the product.
So I guess just a follow-up might be, so why are you optimistic, or how optimistic are you that the convalescent plasma might make a difference to patients in these trials? Yeah,
so from the case series and case reports, there are signals there that that patients seem to benefit from the intervention, but we need to compare it with the control group to really make that conclusion. So the evidence just isn't strong enough. If there was more evidence, we could use it in routine clinical practice, but without that evidence to show that it is effective, it should really only be tested within the setting of a clinical trial. The combined evidence from previous experience of using convalescent plasma for influenza, SARS and MERS also suggested that there was a benefit for patients who received convalescent plasma, but again, a lot of the studies were small and the evidence isn't terribly robust, which is why we really think it needs to be evaluated within the setting of a clinical trial. But there is evidence there to suggest that it may be beneficial, and that's why we're keen to study it.
Thank you. I've got a question from Catherine Hanrahan. Please ask your question.
Catherine, you might be on mute.
Catherine, you're on mute, yes.
Sorry, I had a question about hydroxychloroquine. So it's coming out of the ASCOT trial, but I wondered whether it still may have a role to play in pre and post prophylaxis in those trials where it's being tested for that.
I'll get Steve to answer that.
Yeah, thanks for the question. And it's really important point that most of the trials so far have looked at patients similar to ASCOT, hospitalised patients, and where hydroxychloroquine really hasn't shown to be of benefit. But in other settings, it may be. So in particular for prophylaxis, so patients who've not been exposed to the virus and are about to be exposed to the virus, there is potential that acting at that very early stage, when the virus first encounters the body, or the body first encounters the virus, that it may be effective, and there are ongoing trials for that. So one of those is being conducted from Melbourne as well, and I continue to encourage people to participate in that.
Thanks, Steve. I've got a question that Natasha has written in. How many people were given hydroxychloroquine as part of the ASCOT trial before hydroxychloroquine was discontinued?
So I'll answer that as well. So none. As I mentioned, as we got the trial up and running, the numbers really dropped away in Australia. And then once the numbers started picking up again, we had lost what we call equipoise. So our clinicians were no longer confident that they should be putting patients onto hydroxychloroquine. So in fact, we didn't have any patients receive hydroxychloroquine.
A question from Glynis Porter. Is this being advertised Australia-wide as we are in WA?
I might get Zoe to answer that on behalf of REMAP-CAP, and then Steve on behalf of ASCOT, because they are separate studies. Zoe?
Yep, so the REMAP-CAP is a national study, so sites will be able to enter this domain across Australia, and Lifeblood will be coordinating the distribution of convalescent plasma around the country, so it'll be a nationally available intervention for COVID-19.
And Steve, for ASCOT?
Yes, same answer, Sharon. We're a national study. We're including New Zealand as well, and talking to colleagues there about setting this up. So there are sites in WA which I don't think are open for recruitment just yet, but we're working at that.
The next question is from Nathan Bartlett. Nathan, could you go ahead and ask your question?
Yeah, hi everybody. I'm just wondering why convalescent plasma first, particularly given the ASCOT design in patients enrolled have got reasonably progressed disease, and you might think that the mechanism of action for antibodies might not be as effective as, say, something else which is targeting inflammation and or a direct antiviral. So I'm just wondering why convalescent plasma was first cab off the rank.
I might ask Steve to answer that.
Yeah, so great question again. So the standard of care in Australia has moved. So when we started ASCOT, we didn't have any effective therapies. And so, you know, anything was above, I guess, trialled against standard of care. The standard of care now includes dexamethasone for most patients, and also remdesivir for those patients who qualify for that. So in fact, most of our patients are receiving both remdesivir and dexamethasone who will be entering this trial. And in that case, a convalescent plasma will be over and above what is that standard of care. So it's not like they're not receiving any active therapy.
I might just add to that, Nathan, that ASCOT is looking at hospitalised patients, not ventilated. Usually people will have some evidence of pneumonia, but they may not have entered that phase of immune sort of activation where you have a very high level of immune dysregulation. ASCOT is looking at people who are slightly before that stage.
Yeah, that's still considered reasonably progressed. You still got lower respiratory tract illness, which, you know, is certainly a, you know, a step beyond, you know, the first phase of the infection.
True, but it's not the phase of a cytokine storm and immune dysregulation, which you see when people are very sick in intensive care.
Yep.
Rebecca?
Thank you.
Yes, next question, back to Sophie Scott. Sophie, can you unmute?
Yeah, I'm unmuted.
Oh, good.
Sorry. I just wanted to ask, and this is probably a question for Sharon. The Victorian government's expected to announce today that there's 723 new cases in Victoria. I just wondered, given the big increase, whether you have any ideas about what changes to stopping the spread might be needed, or what does that suggest in terms of where we are in the pandemic, given this massive increase that we're expecting today?
I'd first want to know a little bit about where those cases are diagnosed. So the details are important, not just the numbers. 723 would be a disappointing number to report, of course, because we've been seeing declines over the last 3 days. But I'd need to really understand a little bit more about the epidemiology. Where are those cases coming from? Yesterday, we heard from the Victorian government from Brett Sutton, that a large number of cases from yesterday were in the aged care sector. So before saying what would happen, I'd need to know. I think the epidemiology is important. So it would be a target. It could be a targeted response depending on the epidemiology. If it was widespread community transmission, and with the interventions we have already, the government may well consider additional restrictions to movement. There's some of the things that I think the government will be thinking about with that sort of number.
Thanks very much.
Does anybody have any further questions? There are no further questions at the moment, but if you'd like to raise your hand if you have any further questions. No? Okay. No more questions, Sharon.
Okay, well, that's great. Well, thank you to all our speakers. Thank you, Rebecca, and thanks to the participants for joining. We look forward to hearing more about donation of convalescent plasma uptake, and I'm hoping very much for some good results in both REMAP-CAP and ASCOT. Thanks, everyone.